Okay, so welcome to the session, Plenary 6. I always think with conferences like this, it's only the best people who stay till the end, so well done, okay? And to show how best you are, if you're sitting at the back, why don't you come a little bit closer, because we'd like to see you, okay? So, don't feel shy. If you want to move, that worked. Okay, all right. Okay, so we've got a session, it's Plenary 6. The title of the session is Data, Research, Innovation and Therapies, New Thinking and New Directions. So I'm going to chair the session. I'm Martin Knapp. I'm Professor of Health and Social Care Policy at the London School of Economics and Political Science, which, as I said to people the other day, is about 30 minutes walk in that direction, so quite close to here. I do lots of work in the dementia area, including being the co-lead for the STRIDE project. Some of you were at the session we had on STRIDE earlier, some of you were other sessions. We are having a big STRIDE event on Wednesday, online and in person in London, so if you do want to dip into that, please do, and you'll find there's some documents around you can get us. Okay, so what I'm going to do is introduce, we've got 3 speakers, they're each going to give a presentation, then we'll have time for Q&A afterwards. Just to check, if you've got questions, if you're online, then you can put them through whatever the chat function is and somebody will get them onto the screen magically here. And if you're here in the room and you've got questions, we can do it with the microphone later on. I think I've done all the things I should do to introduce the session. So we're in the order, it's going to be Katrin, then Rhoda, then Tetsuyuk, and there's a logic to that, which I didn't quite listen to what Katrin was saying, but it's going from one level to another, but it's different from perhaps the order in the program. So Katrin Seeher is from WHO. So Katrin is a psychologist by training, but she's working in the dementia field for a very long time, for 15 years or more. Within WHO, she's responsible for the implementation of the Global Action Plan on the public health response to dementia, which I'm sure you know about, and we've heard a bit about that at this conference already, and the monitoring framework, which is the Global Dementia Observatory, which we've also heard a bit about. So Katrin's going to give us an update on where we are, update on the Global Dementia Observatory. Katrin.
Thank you all, and congratulations to Paula and the entire ADDI team. It's fantastic being back in person, meeting so many people, and the last 2.5 days have really been a great pleasure and a great exchange of what all has happened over the last few years. This particular plenary is I'm very excited about because it is about data and innovation, and to use the words of our WHO Assistant Director General, Dr. Fall, data is really the foundation of our work every day to promote health, to keep the world safe, and to serve the vulnerable. And this is also it's not only summarizing our WHO mission and a program of work, but it's also very close to my motivation when I first started or joined WHO at the end of 2015. To help countries monitor their dementia response, what's happening on the ground when we started to develop the Global Dementia Observatory. And I'm particularly proud and happy to give you a quick overview and share some insights with you today on where are we in the area of data and where do we need to go. I think during the pandemic, we've all experienced firsthand how crucial and important up-to-date data are. They inform our policy making, they inform service planning, and we've all been touched by the decisions that our governments have made by looking at what's happening with COVID numbers. And several times during the pandemic, I kept asking myself, where would we be in the dementia area or in the dementia sphere if we had the same access to data that we had for COVID-19? Where would we be in terms of our policy making or service planning? Where would we be in addressing health inequities that we see or that we only understand if we look at disaggregated data? How would we prepare for health emergencies? And so it's these kind of questions that I kept asking myself and thought, okay, we have a long way to go still with dementia. And it all comes down to having data sets that are linkable. And I'll come back to that in a second. But first, I want to introduce you to the Global Dementia Observatory, or GDO for short. So many of you may have seen this framework already. It's the monitoring mechanism of the Global Dementia Action Plan, and it operates on three main domains, basically: policy, service delivery, and then information and research. And on the other axis, you have the 7 strategic action areas of the Global Action Plan. And they are really the technical areas that a country can decide to work in. And within that matrix structure, you have 35 indicators and sub-indicators that help us measure progress on each of the actions that are recommended in the Global Action Plan. So it is quite comprehensive. You can also think of the GDO as a logic frame, where at the far right end of it, we have the vision of the Global Action Plan, which is a world in which dementia is prevented and people living with dementia and their carers live well. They receive the care and the support that they need to fulfill their potential with dignity, respect, autonomy, and equality. That's really where we want to go. How does the GDO help with that? You have in the logic frame, as you all know, you have at the impact level, we can define for each of the 7 strategic action areas what success would look like. And you can do that globally, or every country can do that for themselves, based on what really matters in that country. And now then the 35 indicators and sub-indicators that we have, they really, within the logic frame, form the inputs, the outputs, and the outcomes that help us either, like snapshot, doing it one-off, or over time, measuring how we're making progress, how we're reaching to that vision, basically. So to just walk you through one example of how that logic frame works, we could look at the area of awareness raising and dementia friendliness. So at the input level, we can look at whether a country has a dementia plan and whether they, in that plan, prioritize awareness raising, stigma reduction, or dementia-friendly initiatives, for example. We can then look at the output or the service delivery level, see if the country actually runs any awareness-raising campaigns and to what extent. So it's this interconnection between the different indicators and to what extent they represent the logic frame that helps us understand what's happening in a country. And ideally, over time, we would see that countries are making progress across all these areas and walking towards outcomes and having an impact. You have seen this slide on the very first day. Tarun presented it. So at the moment, we have 62 of WHO member states contributing their data to the GDO. They together account for about 65% of the global population, or 75% of the population if you only look at people above 60. That's not too bad, but we actually want to do a lot better. So towards the end of this year, we're preparing for the second round of GDO data collection, and we want to reach a lot more countries then. Because one particular problem or limitation that we currently face, you see it here on the slide, is that participation in the GDO is very uneven. There are some regions in the world where we have almost 50% of member states contributing data, but you see there's also the region of Africa where less than 10% of countries are represented. So we do want to enable them to deliver or share their data in the next round. So let's look at what information we currently have. And here we can look at what countries routinely at the moment collect in terms of dementia. We know that less than 1 in 5 countries routinely collect data and report on it in a dementia-specific report. And these are the green proportions that you see here on the slide. Most countries either don't compile information or only do normal health or use general health statistics to report on dementia. But if you look at what type of information countries have, there is actually quite a lot of information available. We have, for example, 47% of GDO countries, they monitor routinely the prescription of antipsychotic medication or any other prescription medication. 44% of countries monitor the number of hospital admissions and can at the same time also record diagnoses linked to that hospital event. But fewer countries monitor then what's happening in outpatient clinics or for outpatient visits or what's happening at the primary care level, for example. But just seeing that spread and different types of data sources available in a country gives you an idea of how powerful a health information system could be if these individual data sets were actually linked and would talk to each other. In an ideal world, that would be possible. We do, of course, know that that's not always the reality. But just entertain the thought or the idea of a country using hospital records and dementia diagnosis in hospital admissions for their source information for number of people diagnosed with dementia in that country. If you were only to use hospital records, you'd underestimate the number of people diagnosed with dementia because not everyone is presenting to a hospital. And we know that the records not always are correct. So not always, if a person with dementia is admitted to a hospital, does that record make it into the health record. But if, again, these data sources were able to talk to each other and you had a unique patient identifier that actually shows you what's happening, where do people present to the health system, where do they seek treatment, and you can combine all that information, you get a much broader picture, and ultimately the number of people diagnosed with within a country are much more accurate. And that is also what we're seeing in the GDO, so that countries that have electronic medical records that are able to combine at least a few of these data sources and even have unique patient identifiers, they're much more able to present or to share data, and reporting becomes a lot less cumbersome, let's say. But let's go back to a demonstration of what we do with GDO data. For example, we can look at countries within the GDO that have a dementia policy and have prioritized within that policy awareness raising and stigma reduction, because I used that example earlier. Because if you remember, we have that logic frame and we can use different indicators to measure basically the same action area. We see that of those countries that do prioritize awareness raising, 87% also ran awareness raising campaigns, and 96% of these countries actually implemented a dementia-friendly initiative. Now, we can't say whether that is causal. The policy might not have, triggered these activities to occur. But what it does show is that there is a congruence, there is an alignment between policy-level commitment and then action on the ground. And we can use different GDO indicators to look at this. And on the far right hand, we also see that having a dementia plan is also increasing your likelihood of having action. I'll go to the next slide and you see it much better. So the green bars are countries with a national policy, and the orange bars are ones that don't. And then the individual groups represent different areas or global targets. And so you do see that having a dementia policy actually does increase the likelihood of action happening on the ground or within that service delivery domain. Again, can't claim causality, but at least it's striking and might be another good argument for when speaking with ministries. But so far, we've only spoken about how are we using at the global level the data that we have. But when the GDO was first developed, the idea was actually to create something that is helpful to countries. So I want to quickly show you how our member states can use the information that they collect. And the easiest way to visualize this is by looking at the GDO country profile. So you see again the 7 strategic action areas, and then the small lines are each of the actions that are recommended in the Global Action Plan. And by using a simple traffic light system, you see for every country that's participating, where are there areas where action is required, where they're not yet fully implementing the recommended actions. And then in policy dialogue and with discussions with the local stakeholders, you can together identify which of these you want to tackle first, which are the most important ones. And then, so here you see again, this is an example for the risk reduction area. But then importantly, we did not just want to do a data collection or have a data repository and show problems or identify challenges. We also wanted to use our common knowledge and experience in this area to present solutions. And this is how we came up with the knowledge exchange platform. It's actually fed by resources that the likes of you submit to the platform. All resources are then peer-reviewed by dementia experts, and I must say a wonderful, dedicated group of people with lived experience of dementia who really review and scrutinize the resources that are being submitted, and to make sure that as or if we're sharing best practices, we're also making sure that they have an impact on the lives of people living with dementia. So I really want to encourage you all, if you are working on any specific areas or resources, do submit it to the platform. Join as peer reviewers or join the focus group. I think this is really it will ultimately help us with the implementation of the action plan, because, like I said, it's not just about knowing the data and having the information, it's also being presented with some solutions. With that, let me just quickly summarize what I've spoken about so far. We know, or no one would argue, that access to accurate data is absolutely important, and we do need to strengthen the health information systems that countries have. Not enough progress has been made over the last 2 years. Let's be honest, and we do need to pick up significantly. The GDO is one tool to help but we also do need the commitment and the help by everyone to submit data. And with that, I think I'll come to a close. I'm really looking forward to hearing from the other panelists on their perspective on data. This one was specifically focusing on what member states do. Thank you very much.
Great, thank you, Katrin. It's great when people present nice and clearly and to time and so on, so wonderful. Thank you very much for that. If you've got questions for Katrin or comments, just bank them for the moment. We're going to go on to the other two speakers and then we'll have time later on. So the second speaker is Rhoda Au, who's from the Boston University Schools of Medicine and Public Health. She's Professor of Anatomy and Neurobiology, Neurology and Epidemiology, which is the longest title I've had to read out for a long time. So Rhoda, over to you.
Thank you. All right. Oh, there we go. All right. It's a little, I can see it here. All right. So I'm here to try to stretch your mental boundaries, right? And it's really thinking about how do we use technology to do that. And one of the things I like to always remind us is that technology's purpose is not simply to do a better version of what we're already doing. It's supposed to fill these gaps. And we've been talking for the last couple days about lots of gaps. So that's what you need to be thinking about. You need to be thinking about what is it, what are the tools that we have or the tools we need to develop in order to fill these very important gaps. So I'm going to just start setting the stage. It's the stage everybody's been talking about, which is, and first I have to tell you my disclosures. So there are my disclosures. I'm a scientific advisor. It turns out, this is very interesting to me actually that I even have disclosures, because I didn't used to have disclosures. But because of interest in digital, I think what's most important to take away from my disclosures is people are now interested in what digital technology can do. And so this is for me very recent, because for whatever reason I've been tagged the digital person, which is really laughable because I like to remind everybody that I make my smartphone dumb. But in any case, so we'll move on. So we're all here because we all know the world population is just getting older. And as a result of that, it has led to this worldwide problem that all of us are trying to address, okay? But here is the big problem. So we have a global problem, but where is the science actually happening, right? So this map shows you where the bulk of science is really taking place. And the big thing is, of course, to notice how much of this map is white, right? Those are blank spots of where science is not happening, and that's a big problem. So what happens when you have really, really biased data that we all know about? You end up getting really biased science. So it turns out that if you look at the production of scientific, for instance, papers that are coming out, they're coming out from a very limited perspective of the world. And that's a problem. I think one of the things that I really took away from being here, and this is my first meeting here, is how important it is to hear from the perspective of many different eyes. And we're not getting that in our scientific literature. That's a big problem. So now, one of the things that's very interesting when you do research, everybody always says, oh, you do research. You're trying to do new discoveries, new ideas, new inventions. Well, it turns out the reality of trying to push new research forward is really hard, okay? And I love this cartoon because it really reflects what I think I lived through, which is everybody wants to do something big, bold, but hang on to the same ways we do it. And if you do that, you're not going to change. And so that's, I think, a really big message that you have to take away. There's a reason we have these gaps, and we have these gaps because of what we're doing. So what we need to do is probably stop doing them. So this is really where we're trying to get to, right? And the question is, how are we going to get there? How are we going to get to a world that represents everybody, not just some? So technology, as I mentioned, is, I think, where the solution lies. And again, technology is supposed to be about filling the gaps of what we're not doing, not just simply reiterating what we are doing. It's not good enough to do it a little bit more efficiently, a little bit less costly, a little bit, giving us the same kind of data a little bit differently. That's not sufficient. So for us to get to this idea of real inclusivity and to really get to this global vision, we're going to have to rip up a lot of things that we take as standard. We have to rethink our study design. We have to get rid of the concept of exclusion criteria. How do you be maximally inclusive if all you do is set up exclusion criteria? Exclusion means you're leaving people out, right? So I don't understand why we always focus a lot on our exclusion criteria, because all we're doing is we're setting ourselves up to not include people. Study protocols. We're going to have to rethink what we think is sound scientific protocols, because they're leaving people out. We have to get rid of our old ways of thinking about how we do analyses. We're going to have to collect data in a very different way, which means we're going to have to figure out how to analyze it in a very different way. We have to get rid of the concept of gold standard. One of the things that I always like is when you do something new, right, and you bring in a new technology, people always ask, well, how does that stack up to what we have been doing? Why would we want to continue to replicate what we have been doing when what we have been doing isn't doing what we need it to be doing? So I think we need to start rethinking the concept of gold standards and understanding we actually have to figure out how to set new ones. So the question is, how do you start? And what I'm going to do is talk to you about the ways in which I've at least tried to start and those of my team. So one of the things that we capitalize on, so I always say it's very important to start with the problem and then start to think about how you're going to solve it. Because often what we do in science is we tend to fit our science into the methods. And what we need to start thinking about is how do we fit our methods into the science, right? So if we want to talk about global, if we put that as our priority, what is the most penetrating technology in the world? It's the smartphone. It turns out there's 6.6 billion people with a smartphone. That's a computer in everybody's hands, right? A smartphone has multiple sensors in each one. There's about 27 minimum sensors in every smartphone. Okay, those are data collection, capabilities right there. And within the next year or two, we're going to see near worldwide penetration. It's going to exceed 7 billion people who have these smartphones. So we have got to take advantage of that technology. And so that's where we have centered a lot of our initial efforts. So what I want to do is first introduce you to some initial work we started at the Framingham Heart Study. And I'm not sure, just to remind everybody, the Framingham Heart Study started in 1948. And what's important to remember about the Framingham Heart Study at that time is that we did not have the concept of risk factors. Okay? Framingham actually coined that term. 1961, it published a paper which for the first time ever defined the risk factors for cardiovascular disease, which we take for granted. But in 1948, we did not know that blood pressure could be high. We did not know that cholesterol could be high or glucose levels could be high. So Framingham actually took this bold step of starting this new program without any concept. It coined the term risk factors and opened up the whole concept of preventive medicine, right? But we didn't have that. We didn't know that back then. So I think that Framingham is a really good example of, we essentially are where Framingham was for the heart in 1948. We're not that far off right now as to where we are in the brain. And so I wanted to introduce you to some of the work that we're trying to leverage what Framingham has done in the past in terms of what we're doing now. So I'm going to focus on our cognitive aging studies. And what I wanted to introduce you to is in some of the ways in which we're using digital technologies. So one of the things I did was I introduced the use of a digital pen. And this is a very simple solution, actually. You know, we, as neuropsychologists, we make people write down their responses to lots of different tests. Well, it turns out all you have to do is substitute that regular pen for a digital pen and suddenly have a digital tool. So what you're actually seeing is that this is how we would track people's performance on a test in a way that we've never been able to do before. And then in addition, we added the concept of digital voice. We started recording people's spoken responses to digital voice. And just to give you some timeline, we started to actually record digital voice in 2005, and we started to use the digital pen actually in 2011. And the reason that's really, really important is, you know, both writing and speaking, those are always reflecting your cognitive, you know, capabilities, right? It's a very complex task to talk. I'm using lots of cognitive processes right now. But the idea here is that we can capture your behaviors in a way that a normal test can't, right? And so, and here's the other thing, because we have to think globally, right? Most people speak. And think about capturing digital voice and how easy it is now when you're holding this phone in your hand and you have this digital recorder. So that's the power of what we started with both the digital pen and voice. And then more recently, and we're about to launch now, starting to use the smartphone itself as a tool to collect more data. So we have identified a number of different applications that pick up screen-based behavior, as well as recording more digital voice information. Because we're doing it on a smartphone, we can ask people to do it about every 3 months, and we're going to do it for about 3 years. So suddenly we went from asking people to come into a clinic, giving them some tests, being able to do it once a year, twice, once every 2 years, often it's once every 5 years, to now being able to collect it on a more continuous basis. And I think what we're going to do is we're going to start to be able to compress the time in which we're going to be able to start to pick up these signals of changes, which we need to do because we've heard a lot about the importance of early detection, right? Earlier is always better. And if we're collecting this data on a more continuous basis, and you know, we'll get a little bit of bounce and whatever, but we can start to pick up people's trajectory of changes through these digital metrics that can be far more sensitive than what we've been doing prior to that. So then, you know, Framingham Heart Study, that sort of launched, you know, a lot of my digital efforts, moved it into the BU Alzheimer's Disease Research Center, and really tried to expand that digital footprint a bit. So we took sort of a lot of the work that we're doing at Framingham, and then we started to add some applications. You know, as the one thing about digital technologies is there's new ones coming out all the time. And so we've been able to sort of add some more smartphone applications, some more in-clinic applications. I'm very interested actually in this technology. This technology, Solo AI, is a company out of Israel. And they actually use the camera in your smartphone, and they can track micro-expressions in your face, right? And so even when you have a mask, they can sort of pick up sort of your mood, your different kinds of, emotional related behaviors, but also cognitive. You know, I'm sort of the one who introduced them that it's also a cognitive metric. Because imagine if you're giving someone, you know, they're taking a test, they're listening to an instruction, and they're not quite understanding, right? It's going to be expressed in their facial features. So I'm really excited about this because it picks up these micro expressions that are both cognitive as well as mental health related. And then where I think really things really need to go, and this is really sort of a starting point is we really actually have to get to passive engagement technologies. So right now, most of the health technologies out there require you to do something. You have to enter it, you have to answer questions, you have to do things. What we really need to do if we want to get into this new world of monitoring behavior on a continuous basis so we can pick up these subtle changes, we have to get to the point where we're collecting data passively, which means that you don't have to do anything. It's picking up your behavior. So for instance, a couple of applications, as you're using your smartphone, it's picking up you're swiping, you're typing, et cetera, you're pausing, and all sorts of those behaviors. And once we start to understand these passive behaviors as a reflection of, for instance, cognitive behaviors, that's where we're actually going to get to this future that we're talking about. And so I think that this is really where the future is supposed to head. Then in addition, starting in January of 2021, we have the Davos Alzheimer's Collaborative. So this was launched out of the World Economic Forum. And I think Phyllis Farrell had presented yesterday, I believe, about the healthcare preparedness program. Well, we have another arm, which is the Global Cohort Development Program, which I'm leading. And this is really to take this concept of the fact that digital provides you an opportunity, and I like to call it equal opportunity science. And so we can harness sort of the power of digital and bring it globally. So we take sort of both the tablet, which you can do within the clinic, and then we take the smartphone. We add to it the same kinds of digital testing that we're doing both at Framingham and then as well as the BU Alzheimer's Disease Research Center, but now we're trying to push it out across the world. And so I just wanted to give you a picture of this map. So I just mentioned DAC, we call it DAC, Davos Alzheimer's Collaborative. DAC just started. It was just launched last year. I was brought on actually in February. And I want to show you this map because this really shows you the power of digital. Because we have been able to find cohorts across the world that are interested in being part of DAC. And it's on the basis of this digital protocol. Because when I tell our cohort PIs, this is about using your smartphone or your tablet, their response is, we can do that, right? That's the penetration of that technology. So we formulated our entire protocol around technology that exists. So we're about to launch in Malaysia. And what's very interesting, this is a fact I learned about Malaysia, there is 200% penetration of smartphones in Malaysia. The average person has 2 smartphones, not 1, right? So that's why when we go to this digital focus, we suddenly open up the possibility of engaging not part of the world, but all of the world. And at the end of the day, why is this going to be so powerful? Because everything we do through our brain. So whenever we're engaging in anything, we're always reflecting our cognitive capabilities. What we have to do is we have to change our thinking about how do we capture it. And that's what I think digital can allow us to do. So I'm going to then focus in on the importance of data, because it's really great to collect all this data. But one of the things is this is new. This is a new frontier, wild frontier. We have this concept now of digital biomarkers out there, but we have to find them. We have to identify them. We have to validate them, and we have to do it at a global level. And the only way we're going to do that is if we come together and we share this data. And so Tetsu is going to come up next to tell you the power of what the Alzheimer's Disease Data Initiative is doing, but we're partnering up with them. We're taking all the data that I just told you that we're collecting at the BU ADRC through the Davos Initiative. I am going to get Framingham in there as well. We're going to bring in all the existing clinical data. We're going to merge it with all this additional digital data, and we're going to use the ADDI to allow us to do this in a way that still protects and respects the data ownership of each one of these different cohorts, right? Everybody, I always say, it's not my data, it's your data. So my The only thing I'm asking is, can I borrow the data? Can I borrow the data to use it to solve these particular questions? And Tetsu will tell you how the ADDI can enable and make that happen. And so I think that once we're able to bring all this data together and make it accessible to researchers, and there are lots and lots of really smart researchers all over the world. We've heard some of these voices over the last couple days. That's the voice of research that we need using this data, not just some, but all. And I think if we do that, then we'll get to this global vision that we have. So I'm just going to end by just mentioning that when you try to push the boundaries of where you are to where you need to be, it's actually really, really hard. It's like swimming upstream. And what all I can do is say, you have to keep on trying. So thank you very much.
Wonderful, thank you very much. People who know me know I'm a data nerd, so I'm loving this session, so this is great. So thank you very much, Rhoda, for that. So I'm going to go straight over to Tetsu Maruyama, who is the Executive Director of the Alzheimer's Disease Data Initiative based in Japan. Tetsu, over to you.
Thanks, Martin. Okay, so this is it. The last plenary, last talk of the last day. Just me between you and what you'd rather be doing on Saturday afternoon, which gives me an enormous sense of power. Although I'm told with great power comes great responsibility, so I promise I won't abuse the time that I have here. The simplest, most efficient thing I can say is what Rhoda said, and then we can leave it at that. But I will talk a little bit more about the Alzheimer's Disease Data Initiative and about the role of data sharing in making sure that we understand the disease better and that we develop the treatments that people with dementia and the people who care for people with dementia really need as soon as possible. I can spend very little time on this one because you really don't care that we're a nonprofit organization, blah, blah, blah. But our goal is to transform Alzheimer's disease research and accelerate progress. So what that means is data sharing is not an end in itself, but it is a means by which we expect that researchers and people in the community who care about the progress against Alzheimer's disease can do that faster, better, more efficiently. In 2017, Bill Gates made a commitment to engage with the Alzheimer's research community and to do what he could using his voice and his resources to help move Alzheimer's research forward. And in doing so, outlined 5 key areas that are going to be familiar to everybody in this room that we need to do better. We need to understand the biology of the disease better. It's a disease of aging, and we don't understand aging very well. It's a disease of the brain, and we don't understand the brain very well. So at one level, it shouldn't be surprising that we don't understand this disease of the aging brain. But we need to if we're going to develop effective treatments. We need better diagnostics and biomarkers. Again, everyone in this room is even more aware than I am how difficult it is for a person with memory concerns even to get a diagnosis of dementia. And partly that's because we don't have the objective criteria that we should use to have them. And the biomarkers that will help us run clinical trials that are more meaningful and more objective are also lacking right now and need to be developed. Therapeutic pipelines at the time, certainly in 2017, although I think there's been some really encouraging progress since then, but at that time they were very focused on a single approach. And the idea that we needed to diversify or take more shots on goal was something that we took on board early on. Clinical trials themselves seem to be more difficult, longer term and more expensive in dementia and related disorders than they do in other areas. There are tools that we need and that we're investing in to make sure that we're doing our best to reduce the time and the cost of positive trials of Alzheimer's therapeutics. But underlying all that is data. And we ask the question, can data be our friend in helping to solve this massive problem? I think the answer has to be yes, it can be our friend, And then the next question, of course, is how can we make it our friend? And this was the situation that we were faced with at the outset. Data exists, important data exists, but it exists in islands. So let's take Rhoda's data that she's just been telling us about, for example. These great new advances in how we can measure function, how we can measure cognition with digital means, using everyone's smartphone as a way to collect data. All over the world, we're setting up sites to run trials that are going to collect those data, analyze those data, and use them. Now, what if they just sat with the people who collected them? If out of all the people who are interested in Alzheimer's disease, all of the people who might make a contribution to it, only those people who were selected to be part of Rhoda's study got to use it. It would be, well, fantastically useful because Rhoda's choosing really good people to put in her trials. But if somebody else who was really interested and an expert in that area or had a machine learning algorithm to apply to it or a different way of thinking about it wanted those data, they couldn't get it. Or they could get it only with great difficulty. So the data sat in these islands, and if you had a question to ask about the data, if you had code that you wanted to apply to a data set, or if you had data yourself that you wanted to share with other people, you could only share it within those islands. It was doing good, but not doing enough good. If you wanted to get access to more than one set of data, you had to log into multiple sites. You had to go through different, very exacting procedures to even put an application in to find out whether you were going to get access to those data. And then more often than not, if you did get access, you were told download it to your computer. So that meant data sharing means data copying. Now there's multiple copies of these data out there. Once you've shared it with someone who's downloaded it, governance is lost to you. You don't know what happens to it after that. So there are security concerns about that as well. You've got to use your own computer to do it. So maybe if you're sitting at MIT, you've got all the computing resources you would ever need to make the most of those data. But if you're sitting in other parts of the world where dementia is a serious concern, you want to make a contribution, and you don't have a supercomputer in your basement, then you don't get a chance to analyze those data or use them in the same way. And so all of this encouraged siloed research. Siloed research makes it harder for us to come together as a community and create an overall theory of how to attack our enemy, Alzheimer's disease. So it wasn't just us, obviously. The initial effort in this regard that led to ADDI was a consortium of people who shared this concern and wanted to do something about it. And I won't read out all the names, but you can see there are nonprofit groups, there are patient advocacy groups, there are major philanthropic undertakings, there are government research councils in this, and there are pharmaceutical companies. Biogen was in from the start. Recently, we've added Eli Lilly, thanks to Phyllis is in the room somewhere. Okay, well, she was here earlier anyway. And this was a great start because it indicated that data sharing is something that across a number of different sectors, people are willing to work together to improve. So there are three basic ways in which we are working to remove these barriers to data sharing that we believe are barriers to progress in the disease. One of them is to make the existing data platforms interoperable to increase data access. What do I mean by that? There are great existing data platforms. For example, the Dementia Platforms UK here in the UK has a tremendous number of important studies that can be contributed. The Alzheimer's Association, their Global Alzheimer's Association network, GAIN, also is a great way to identify cohorts and to build a single cohort that you can interrogate. In some ways, it has some studies on it, doesn't have other studies on it. So the idea would be to find a way to make all those interoperable. If you go on to GAIN, you can discover not only the data sets that are already there, but the ones that are on DPUK or the ones that are on Vivli or other platforms with which we're working right now. And we conceived of the Alzheimer's Disease Workbench, the ADWB, as a way where you could go as an individual, get an account for free, get a workspace in which you can work with permission on record-level data for free, and then see data all over the world. We didn't have to recreate it. We didn't have to reinvent it. in the way that Rhoda was talking about. We just want you to be able to connect it all together. While there's a lot of good data available for that right now, there could be more. So people are collecting important data sets all the time, all over the world. We are encouraging more people in more parts of the world, as you heard from Rhoda, to do this. But it's not guaranteed that those people are going to share the data once they're collected. The more we can make it the norm for people to share the data, the more we can make it easy for them to share the data, the more we can address their concerns about the safety or security of sharing their data, the more data will be available for everyone in the world to use. And that's part of the third platform as well, is that we want to build an enabling environment that's going to empower researchers. Well, what do we mean by building an enabling environment? Part of it is just that if you go onto the ADDI workbench right now, and I'm not a data scientist, I'm a basic neuroscientist by background. If you go into the ADDI workbench right now, you can get a workspace. You can do some searching to see what data sets are available. You can look through data dictionaries to find out what categories of data are on there. And then if you're not a data scientist, then you're stumped. Okay, what do I do next? How do I do something with this? So building an enabling environment partly is about giving people the computing resources, but it's also about building the tools, building the environment, building a community around that we call ADDI Connect, which is not only about how do I use the ADDI workbench, but once I've used it, how do I share my findings with other people? How do I share hypotheses about these? How do we build a global ADDI research community, not the only one, but an important one that is inclusive and helps us address these issues as a larger society. So this is what we think the world is going to look like as we achieve our goals here. And you remember, rather than being siloed now you have all of these 3 data sets, but because they're interoperable, anyone who has a question, anyone who has data, anyone who has a hypothesis, anyone who has code can reach all of these things and each other. And as I mentioned before, we have 2 products in our suite right now that are, we think, particularly important or valuable to researchers, and that's the ADDI Workbench and the ADDI Connect. The Workbench is where you go to do your data science. So it has access to this global platform along with the tools and resources. We've made a commitment from the start to do this at no cost. So if you're contributing your data to the ADDI Workbench, or you're going to open a workspace, to open virtual machines, to use all the tools that are on there, all of those things will be done at no cost to you as the user. These are also collaborative workspaces. If you go open up a workspace, you can invite your collaborators wherever they are in the world to work on it with you as well, and it's as if you're all working on a single computer. And that removes the barriers of distance as well. With our platform providers in the Iridia digital research environment, we've optimized the security and the provenance of this so that record-level data can be transferred into your workspaces safely and securely. But at no time, if you are a data contributor, will anyone get access to your data without your permissioning it in a way that you are comfortable with. If you want to let us have the data and give permission ourselves, as Lilly did with their JARA study, then we're very happy to take that on. But if you feel you want to make sure you know who's using your data, we can accommodate that as well. Obviously, our hope in the end is that people will be more inclusive and more open to data sharing. But it's not just about providing those tools, as I said before, it's about providing an environment, a community. Because once people have made discoveries using these data, we want them to find the fastest possible means to share them with anyone who might be interested in using or understanding those. The peer-reviewed publication is always going to be, sorry to use the term Rhoda, but the gold standard for scientific output. But at the same time, it can be very difficult to get a peer-reviewed journal to publish data that might be challenging to the status quo, or that might be negative or seem negative in that it didn't prove what everyone wanted it to prove. As quickly as possible, we want people, when they found that, to be able to share that with the community. Hey, I found something I didn't expect to find. I found something unusual. I found it difficult to replicate what somebody else did before. Let the community then be the ones who can make sense of those data and use them to move on. So the ADDI Connect, which we just launched last week, if you go to the ADDI website, you'll find a portal to ADDI Connect. Please join and share. It's to build and support the data sharing communities. I said, we hope it's a way of breaking down silos, because not only can you share the data now, you can share the outputs of the data. And we want to use it to encourage diverse users to engage and connect with other users. And that's a key part. Users from all over the world. Rhoda is, through the DAC, continuing efforts to collect data from places in the world where data have not been collected before. That's not enough. We want to empower the people who are living in those areas to use the data, to have access to data from other countries, from rich world countries where they may not be able to access that, to have the computing resources to make sense of that and then share them with the world. These are important silos that need to come down. So we're on our way to doing that. Our data users are global. They come from everywhere. We had said Argentina to Zimbabwe before, but apparently we just got a user in Albania, so we are now Albania to Zimbabwe. 2,600 users from over 80 countries, including 400 users from low middle income countries. Again, it's great to have them as users. We need to do more than that. We need to encourage and enable them to use those data. They are a diverse group, and this is something we wanted from the start. There are data scientists in there. There should be data scientists in there. There are bioinformaticians, people doing drug discovery, basic scientists, clinicians, and very clever people who haven't worked in this field but care deeply about dementia and want to be a part of this community. The data sets that we're bringing in so far, and we've got 40 plus right now, and we're working on bringing in more all the time, are also going to come from everywhere. Obviously, the concentration of them, as you've seen from Katrin and from Rhoda as well, are in the US and in Western Europe, but we are beginning to bring in through DAC, through Worldwide Fingers, for whom we are also looking forward to providing platform support, cohorts and studies representing people all over the globe. This may be a little bit specialist for some, but the data sets that are coming in are varied. Many of them are coming from academia, longitudinal cohort studies, other more specialized studies, and increasingly we are able to bring in, particularly through our partnership with Vivli, to bring in data sets from industry. You will notice, though, those of you who are keen-eyed and still watching the presentation, that an awful lot of our industry data sets are coming from PPAR gamma agonist tests and from BACE inhibitor tests, and that essentially none of them are coming from immunotherapies such as amyloid antibodies or tau antibodies, or from any other mechanisms. So this indicates both the promise and the challenge. The challenge is that industry at this point is still reluctant to share data not only from active studies, but from therapeutic targets that are still active. So nobody's doing any PPAR gamma studies anymore. Nobody's doing any BACE inhibitor studies anymore. Companies are far more willing to share that now than their active molecules. We get that, we understand it, but we are hoping over time to build in this trusting community a sense with everybody who might contribute data that they are gaining more from sharing their data than they are risking by sharing their data. So where are we going from here? We are still a very young organization. We've been operating for about 1.5 years. I have met my team face-to-face once. Looking forward to doing some more of that in the future. Obviously, we want to increase the number of data sets we have. It's not maybe a linear relationship, but clearly the more data and the more varied data we bring in, the more the community has to work with. By broadening the type of data that we're looking at, we mean not only the geographical diversity that we've talked about, not only socioeconomic and other kinds of diversities, that we're talking about, but also the data from studies. So if you call yourself an Alzheimer's study, you're clearly right in the middle of what we're interested in, but there will be other diseases that are adjacent to Alzheimer's disease that are equally important. Maybe we will discover later that our whole classification scheme ought to be changed, and if we don't include data that is relevant, but not currently called Alzheimer's disease, we might miss that. So we're bringing in data on frontotemporal dementia, on ALS, on Parkinson's disease, on vascular dementia, and then later, one of our goals might be to say, do we understand the relationship among those as well as we can? Increase the number and diversity of users. Again, the power is in the community. It's great if there's 10 people in the community. It's probably better if there's 10,000, so we'll work in that direction. Build and support AD Connect, and for this we need your help because AD Connect is a user community. So please log in, play around, leave some comments, and build a community that's going to make a difference. And then, clearly identify and support data sharing partnership opportunities, helping the DAC team, to have a home to share their data, I think is really going to enable every aspect of that, we hope, and we want to continue to do more of that in the future. So we'll leave you with this inspiration. Together we can build a future where open data and global collaboration are powering the end of Alzheimer's and related dementias, and I hope that's what we all want together. Thank you very much.
Thank you very much indeed, Tetsu. So 3 really great presentations, great timekeeping as well, very, very good. So we've got 20 minutes for some Q&A. So I've got a screen that says questions will appear here, and the cursor is just waiting to do the questions. That's the online community. So people in the room, questions or comments? Paola. So 2 microphones coming to, well, okay. Okay, so we'll go here and then...
Boss wants one too.
Okay, so the second question is in the front here. But, go on.
すみません。ちょっと通訳を入れてやります。
Okay. Thank you very much.
Oh, sorry.
No.
That's okay. For some reason, it's just... Sorry, Paola, hang on. Oh, hang on. Sorry, Paola. Yeah. Hang on, sorry.
テクノロジーについてちょっと興味があるんですけど、携帯電話を使うことが私もいいと思うんだけど、これを日本で言うと脳が楽をしすぎて脳が衰退するんじゃないかってよく言われるんですけど、そのことについてちょっとお聞きしたいんです。
I am interested in using technology, and my question is, now I use a cell phone, mobile phone very actively, and some people come to tell me that, well, if you rely or depend too much on mobile phone, you would have a decline of your function sooner, so you shouldn't be too depending on it. How would you say to that?
Okay, any of the panelists want to...
Yeah. Well, I think that the use of your smartphone, right, is just a tool. It's so as long as you're engaging it with as a tool to get, accomplish whatever you want. I always think that the more you engage, the better. So I don't really care where you engage, whether it's online, on your phone, offline, it doesn't really matter. I think that, in the sense of cognitive enrichment, we always want you to do more, not less. But it is also true that it could be a signal as you use your phone, and over time, if you actually end up using it less and less and less, right, that could be a reflection that you're starting to have some cognitive changes that are worth looking into.
Okay, and other panelists okay do you want to chip in? Nope, okay. All right. Paola, sorry, you had a false start, so apologies.
I haven't got such a clever question as Tommy one, which was much more clever. Mine is a kind of sort of pragmatic question, and it's for Tetsu. The ADDI initiative is very needed, there is no doubt about that. But it's interesting that recently I was speaking with a university And I was telling them about that. I was like, do you know that there is this thing? Your data is really lovely and sounds like we could all probably get to know a little bit more. Not only they were not aware of ADDI, but they were horrified at the idea that I was suggesting they could share some data, looking at me like if I was a naive newcomer that obviously didn't know that this wasn't the damn thing. So how are you planning, because you've got a vision here, which is multi-year, how are you planning to tackle this very hard barrier of, I would say, negativity, mistrust, and also ingrained habit, when we all know that sharing data in our field may well be the only way forward, given what's happening in scientific breakthroughs?
Well, thanks for giving me an easy one to start, Paula. But it's an incredibly important point, which is that the most important barriers to data sharing are not technology barriers right now. They are behavioral barriers. And I feel in many ways data sharing is like diversity in your workplace, right? Everybody says, oh yes, diversity is good. We want to have diversity. And then they say, oh, I have to do what? I have to work with people who don't work the way I do? I want to do it. I want diversity, but do it my way. Data sharing is very similar. You'd be hard-pressed to find somebody who says data sharing, in principle, is not a good thing. But I'm really worried about what's going to happen to my data. I'm really worried about whether I'm going to get credit for collecting the data myself if somebody else uses my data and then publishes a paper in a higher profile journal than mine. That's a real loss for me as an academic scientist. So I don't think we can go into universities and just say, oh, stop worrying about that. That's not a big problem, because it is a big problem for them. We need to work with that incentive structure so we can say, if you need a chance to publish a primary paper on your data before you share it with everybody, we can work out a data sharing agreement so that's the case. If you want to place certain conditions on who can use your data, at least from the start, it's your data. We're just trying to distribute it to people as best we can. Ultimately, I think this is a movement that has to build on itself. We have to build trust, because it's lack of trust that keeps people from letting go of something rather than make them hold on to it. And so that's why we are really grateful for pioneers. And seriously, I know I've called her name out a few times, but Phyllis Farrell on the industry side said, we've got these GERIS data sets, we want people to have them, here they are, take them and use them. And we hope that that sets a precedent when people find their really interesting findings that are coming out of it. Craig Ritchie and the European Prevention of Alzheimer's Disease program, the IMI-funded EPAD program, has put all of his data as openly as possible to share on AD Workbench. We think great things are going to come from that, but we also need to say that's not going to happen all on its own. We're doing a data science challenge with Roche Diagnostics and the EPAD data to show that real insights in diagnostics can come from these data being shared outside your own group. And our hope is that the more people see how their data are impacting positively the fight against Alzheimer's, the more they will be willing to trust and do it. That is an article of faith, but that's what we're working on. Rhoda.
Yeah, I want to make a comment. Because I am a researcher, right? And I got to tell you, I don't understand why researchers have a concept that it's their data. It's not their data. It's actually, you know who owns the data? The people who gave the data. Yep. It's actually all the volunteers who gave their time and their energy, right? And you know what? We as researchers, we have a responsibility. We actually, first, we have the honor of using their data, and next we have the responsibility to take their gift that they gave to us and put it in the hands of as many people as possible to get to the solution as fast as possible. So I have to tell you, I think we also have to change the narrative. We have to stop calling it my data. I don't believe it's my data. I believe it's supposed to be the data of the people. And if they want to give their data in order to accelerate discovery, we, the researchers, have a responsibility to try to do that as effectively and as efficiently as possible. That's just my comment.
So can I, Paula, can I answer your question differently now? What we need is more Rhodas.
Okay. I think the gentleman sitting here, brown, in the brown, yes. Then Erica and then Lenny.
Hi. Hello. Yeah, so those were amazing presentations, and thank you for sharing. And just this is not more than a question, it's more like a reflection, in my opinion, how you address or how we could address certain inequalities in data, talking about being global and transparent. I myself, I'm a neurologist from Venezuela, for example. Mm-hmm. Venezuela is not, I mean, it's not even reliable on data, in my opinion. We have, authoritarian government. We have a few crises, like a humanitarian crisis. We have a few special situations, and actually that's why we're here today. And we never see, for example, Venezuela in any map. Of these maps you have presented, or any map, right? So there's no data, and so maybe this will be more for the WHO perspective, but how do you guarantee those, or what are the efforts that you're doing to address humanitarian crisis? I'm just saying about my country particularly, but we know there's a war in Ukraine. There's a lot of problems in the world. How do you make it as global and as equal? And I know that's what I mentioned, it's a reflection, because I think in my perspective, we've never been mentioned in this conference as a country, or as we do have Alzheimer's disease, and that's a reflection.
Katrin?
Yes, no, and it's a great comment, and it's a concern that we share when we look at which countries do contribute their data. We do reach out to all our member states, so no one is excluded. There are limitations at country capacity of who can or who has the capacity to collect the information and then share it. There's also issues to do with awareness and whether a country is ready. So the countries that we currently have in the GDO, they tend to be more dementia aware, dementia ready. They have an proven interest in the area. But one particular focus that we do want to emphasize is also the need to disaggregate data and not forget population subgroups, for example, to not forget or focus only on high-income countries, but try to reduce actively some of these inequalities that you've had addressed. And I think the way forward is, and maybe now also picking up from the comments just earlier, I think the big question for us now is how can we support member states in getting better in accessing and using data that we all produce every day. We present to a health service, actually making that connection or that event at a health service measurable and usable, so that it's not so cumbersome at the Ministry of Health level in reporting against it. And I think this is one of the biggest issues, and also I think the closest connection of why you had two presentations that seemed a bit more related, and then mine to start with. But I think this is really where we do need to bring these two topics together and learn and improve.
Thank you very much.
Can I just,
Rhoda?
So this is interesting, this concept of data. So when I first started out in research many, many years ago, I was like, why is this person famous and this person not? Because they both seem really smart to me. And one of the things I realized very early on, it's luck of data. The person who's really well known had luck of data. They had access to data. They had the right patient enter their office, right? Or in my case, they walked into this treasure trove of decades of data. You know, that's what ADDI is doing. It's trying to take that concept of luck of data and democratize it, right? So that it's not in the hands of just a few people. So, you know, so even if your country's data isn't represented, your voice can be represented, your ideas, right? Because you can go in, use the data, and talk about how to use this data in a different way. And that way, I think that's how you get rid of what I think is this uneven luck of data that's driving things.
Okay, going to go to Erica and Lenny, and then we'll come back if we have time. So Erica, so the mic, oh, you got a mic, good.
Thanks for the presentation. I'm Erica Breuer from Newcastle, Australia. This question is for Rhoda and Tetsu mainly, and I'm glad, Rhoda, you raised the point of the data really belonging to the participants. And one of the concerns that I have, and would be interested in what you think, is around what happens to the data, especially with smartphones, and sort of, we put a lot of trust in technology companies and in other companies that are collecting our data. So both in terms of in your research process and also maybe the ADDI, but firstly, how do you make sure that's protected in the research environment, but then at the sort of scale up and rollout phase, what sort of safeguards can we put into place that data isn't abused and really protects the data for that individual?
Let you take that one.
Okay, I'll go first on data security, but I think it's also, I will toss it back to you, Rhoda, when it comes to, you know, particularly around this treasure trove of digital data. Because I will say, I don't know about you, but I find it super spooky when I go onto Amazon and I just browse for something, but I haven't even bought it, and then I open the August science journal Nature, and there's an ad for that thing that pops up. It really bugs me. And I want to make sure that, you know, the really sensitive data that research participants are contributing through this sharing doesn't get used in that way. So there are a couple of safeguards. You know, we are, the data that will be available on the AD workbench is HIPAA compliant, high test compliant. As far as any, you know, legal governance goes anywhere in the world, you know, we will assume that it is at the highest standard. We insist on anonymization of all the data before they are shareable, and that may even involve, you know, for imaging data, putting it through processing pipelines that will strip out face and skull and the kinds of things that could become identifiers. And ultimately, it is the goal, it is the data contributors, and now I'm treading right on this really careful line between who owns the data again, but it is, we feel, between the data contributors, that's the Rhodas, the people who are collecting the data on behalf of the research subject, and the research participants in how they ensure that those data are anonymized and that the uses of it are not going to exceed what have been permitted by informed consent. Then when we take those data, we follow the data contributors' rules. So the chain should go, research participants insist that the researchers who are collecting their data are going to use it in an appropriate way. We follow whatever those data contributors have said they need before we share the data with anybody else.
I mean,
Yeah, I would say,
Rhoda, if you just very quickly, then because we've got two more questions.
Okay.
So.
Yeah, I was just going to say on the collection. Yeah, on the collection side, you know, right now it's a lot of encryption that happens while you're collecting the data. So even if you are able to, you know, sort of get in, you're not going to capture anything. So for us, the key is to get it into these safety, you know, these safe enclaves, right? And then leave it to them to put in the security and the audit trail to show that, to document. So I'll just leave it at that.
Okay, so a question there from Lenny. The hand up again, then the mic man can find you. But there, that's it. So quick question, quick answers, and I'm online as well. So.
Oh, so this song, yeah. So I suppose I have a question around the sort of universalism of the problem, which applies to all the speakers, which is that there are very interesting posters downstairs from King's about kind of health system data and A&E data and the impact of dementia. And actually, to get better A&E, to get better experiences in the health system, you need better A&E data. It's not really better dementia data. And a lot of the other problems that you're describing are around kind of culture of universities and journals and academia and, and how governments collect health system data. So there's a universal problem, and we have a responsibility as a community to do dementia-specific things, but there's also this influence in the wider culture. So it's a question for all the panelists around how do we kind of shift that question to make advances in dementia. We need to make advances in data in general, and that will bring us benefits.
I'm going to moderate it. It's not a question for all the three panel, it's for Katrin.
Okay, I'll try to be very quick. So for WHO in general, like health system strengthening tries to take a necessarily not disease-specific approach, and we say whenever you strengthen the information system or the access to data, you automatically also improve access to all the different conditions. We still felt that the Global Dementia Observatory was important just as a monitoring mechanism of the global action plan. But I totally agree with you. We do need to specifically in low and middle income countries now strengthen their general capacity to collect data, and then it will work or benefit all the different diseases. And that also includes not necessarily just working with the health system, but with all the different sectors that do play a role, and also tackling some of the, let's say, regulatory or legal issues that come with, for example, data protection, that often is a bit as absolutely important and essential as it is, it also is often a barrier at country level. So those are things that we need to address.
Okay. Thank you. We've got one quick question online. I'm going to turn it into a comment, which is, don't you think that one way to promote data sharing involves to change the manner in which scientists are evaluated? It's already mentioned that publications are a major concern for them, but I think it would be very different if funding bodies and universities started putting value on the way in which science is done as accessibly as possible and connecting with the general public. And I think that's kind of in the spirit of what we've been hearing. So we've reached 5:30. I'm going to say thanks enormously. 3 speakers who kept their time, gave us some really stimulating stuff, lots of things to follow up, so let's thank them again. And in return for the pain of me having to chair this, I want to exploit my position and thank Paola and ADDI for organising an amazing conference. So thank you very much. And it's over to final session. Thank you.